I'm going to talk a fair bit about the amount of progress that we've made and how things have changed over the past 40 years, how we assess the totality of the evidence, talk about our recommendations. This morning's talk was skewed towards the ones that are relevant to breast cancer, and that, a lot of these factors are relevant to breast cancer, but there are some that were not so relevant to breast cancer. And talk about some of the gaps. Are we there yet, and what can we do now? So, we are the leading authority on diet, weight, physical activity, and cancer prevention and survival. These are the 3 reports I talked about earlier. I didn't go into so much detail about the, what those changes. It wasn't just a factor of volume of evidence, but also the types of evidence we have, which I'm going to talk about in a moment. That same quote, we know how to prevent cancer, a lot of cancers. Just going to skip through that, distinguish evidence from opinion. So, the third expert report, which came out on the 24th of May 2018, so it's crazy that it's been 5 years already. But really, our focus now is actually on survivorship, because having done all of this work, we kind of looked at the totality of what we'd done and the recommendations, and the fact that recommendations have been pretty stable over these 3 decades. And came to the conclusion that we could keep doing what we were doing and keep sort of summarizing all the literature. But since the recommendations aren't changing, if all we're doing is improving the precision of the estimates for the factors that we know influence your cancer risk, that we should probably move on to areas where we can make some more meaningful contributions. So, but for the third expert report, in total it's about 12,000 pages of content. All of this really gets distilled down into the, and who's got a copy of the printed report? A few of them out there. But there are the systematic literature reviews, which are really the substrates from which all these reports are generated. First of all, there's a protocol that you use to generate those systematic literature reviews, but then those systematic literature reviews get distilled down into a cancer-specific report, whether it's breast cancer, prostate cancer, colorectal cancer. And to give you an idea, the SLR, the systematic literature report for breast cancer, is over 2,000 pages. The CUP report, which is a sort of distilled highlights, if you like, is about 200 pages. So the 116-page summary is just which covers all of the cancers, is really just that, a very pared down summary. But all of this information is available on the website. And you'll see we have these sort of matrices that show certain the strength of evidence for given exposures. And if you don't see a particular exposure that you're interested in there, you can sort of track back up to the systematic literature reviews to see what the evidence is, because there's only so much information that you can provide. So yeah, as I just sort of, I like to think of it as a funnel of evidence. We've got all of this literature and research that's done around the world, and we try and distill it down to be useful to the consumer, but also provide, if you like, that paper trail of how we derived all that evidence. So, AICR has been around for 40 years, and back when we were formed, the focus was really, in terms of things that cause cancer, was on external carcinogens. It was smoking and all of the even when people were talking about diet, it was, oh, there must be carcinogens in the food, it must be the pesticides, it must be that early research really didn't find those mechanisms. So then in the 90s we moved into, well, and my PhD was started in 97, was partly on folate metabolism, partly on xenobiotic metabolism. So the metabolism of those heterocyclic amines and polycyclic aromatics that Dr. Luma was talking about, that whole sort of charred meat hypothesis in colorectal cancer. And those molecules are not actually carcinogenic when you ingest them, but they're activated by enzymes to create molecules that can then bind onto DNA. So that was a big focus in the 90s. It really didn't get us any closer to the answer. It's still, we know the association between red meat consumption and processed foods or processed meats is still strong. We're not exact, and I'll talk a little bit more about the mechanisms later on. But huge amount of work went into it, and we weren't really any further along. But we know that the association was still there. Then we move into the 2000s. Who's heard of the hallmarks of cancer? Excellent. So back in the sort of 80s and 90s, the whole kind of model of cancer was initiation, promotion, progression. And so this really comes from the sort of original genetic models of cancer, where you had the Knudsen two-hit hypothesis. So you have because a lot of what we knew about cancer was from familial syndromes, where someone has one mutated allele, and then something happens to knock the other one out, and then you start getting cancer. So so there was the initiating event. So some people were born, if you like, with that already initiated scenario. Some people it was just spontaneously or acquired somatic mutations. And then you had the promotion phase, and then progression and metastasis. But in the early 2000s, or the year 2000, Hahnemann and Weidenberg came up with the hallmarks of cancer. So these are 6 characteristics of cancer. Basically, what a cancer cell what characteristics it has to acquire to become a cancer cell. And I think the interesting thing about this is that 5 of them are all actually features of benign tumours. So unlimited replicative potential, resistance to growth factors. I didn't intend talking about this part, but I think if you don't know about it, it's all good information to give. And the one that really distinguishes cancer from benign lesions is the ability to invade and metastasize. So around that time, moving from this initiation, promotion, progression model to this acquisition of these characteristics, there was a big change from, rather than looking at external carcinogens and activation of those external carcinogens, inflammation and endogenous processes became a much bigger focus of the research. Then we move into the 2010s, and host factors and the microbiome and metabolism are a bigger focus. And I would say now the immune system is where all the action's at. And certainly from the point of AICR's work, all of the factors, diet, nutrition, physical activity, all impact the immune system. So I think there's been this kind of convergence. We knew diet, nutrition, physical activity was important, but now maybe this is where we're seeing where the rubber does actually hit the road in terms of the effectiveness, because some of the mechanistic work has been pretty hard to get at. So that's a little bit of the history of how research thought about cancer. The next one is how the methods have changed. Certainly from an epidemiologic point of view, back in the 80s, they were all ecological studies, case control studies, and if you've ever seen that sort of pyramid, so the hierarchy of evidence, these are basically at the bottom. You know, there's a lot of them. Case control studies are easy to do, but they're very prone to biases. Ecological studies, almost impossible to remove the confounding. You know, when people would say, well, look at the breast cancer rates in Japan versus the US, and then when people moved from Japan to the US, they acquired similar breast cancer rates. But there are many differences between, it's not just diet, there's all sorts of differences. So teasing all that's really difficult. A lot of cohorts started happening in the 1990s, or we started getting results from longitudinal cohorts. And then by the 2000s, not just the fact that we had enough evidence to synthesize by meta-analyses, but the whole sort of, if you like, the rules and processes for doing systematic literature reviews and meta-analyses were being developed. Still, that's observational evidence. There's a big drive for randomized control trials, but for the kind of exposures that we're looking at that last a lifetime, you're not going to randomize people to drinking alcohol or not over 20 years. So we're still largely dependent on a lot of observational evidence, but where possible, we do synthesize the intervention trials as well. And then now there's a much bigger focus on not just survivorship, but quality of life as well, how these factors, there's much more to living than staying alive. So this is just how our sort of research methods have changed, with higher quality research, more reliable evidence and advice. How we think about diet. So back in the 80s, I'm sure some of you are old enough to remember, everyone was looking for the magic bullet. The beta-carotene studies, which started off with the carrot diet, and everyone's turning a bit orange. My grandmother was a breast cancer patient in the 80s. She was big into it, food processing, pounds and pounds of carrots. And it didn't work. Anyone knows the history of the beta-carotene studies. Basically, they did them in smoke. There were 2 large studies in smokers. The first one reported their results, and they said, it actually increases your risk of lung cancer. So the other big study did an interim analysis and said, we did the same thing, stop doing that. Or we found the same thing. I was diagnosed with a Ewing sarcoma when I was 18 in 1989. My mother was duly giving me beta-carotene tablets. I'm still here, so didn't do too much harm. But it was just this sort of conceptual thing that everyone thought we're going to find this magic bullet. Is it selenium? Is it folate? And it doesn't work. But when these results weren't kind of meeting people's expectations, it must be the genes and the exposure. So all big focus in the 90s and early 2000s on gene-environment interaction. So, what exposure with what gene. And it didn't really tell us very much in most things. As we moved into 2000s, it was more about whole foods and not the nutrients, but the foods. And we've kind of moved even beyond that. Having a dietary pattern, there are more benefits from eating a better dietary pattern than eating lots of a single food. But there were studies that were done in the 2000s that said people that eat more carrots, even though beta-carotene doesn't make a difference, maybe carrots. It's your overall diet that makes a difference. And now we're moving into timing of eating and intermittent fasting. the jury is still out, but there are certainly some metabolic advantages, and cancer has a very strong metabolic component to it. So that's just how, the evolution of how things have changed. And the societal perception, I mean, really, there was very low acceptance in the 1980s that lifestyle could do anything to improve your cancer outcomes or reduce your risk. We came out with our first recommendations or guidelines in the early 1990s, and sort of distilled, a little bit more formalized in the first expert report. But the strongest recommendations, and when they were distilled down to the 10 that look a lot like the ones that we have now, was in the 2000s, in 2007. And really from that point on, people started looking at, if you follow these recommendations, each of the individual factors that makes up each recommendation is based on the fact that it reduces your risk or increases your risk of cancer. But then, so it makes sense that following them should reduce your risk. But it's only in the sort of early 2010s that we started to have the actual evidence that follow, scoring people based on their adherence to a cancer preventative lifestyle made a difference. And now we've moved into looking at those factors in survivorship and quality of life. And early indications are good. So here are the recommendations, and I like this quote from our Karen Collins. She's one of our nutrition advisors. It's a call for action, not perfection. So we do see this gradient, that the more of these recommendations that you follow, the better your outcomes. So, and we also try to make them, as you'll see as I go through, as realistic and as possible for people to meet. We get a bit of pushback for saying, why don't we say no fast food and zero alcohol and zero sugar-sweetened drinks? Because if we do, people just say, well, no, I'm not doing that, and carry on. So we do try to make them accessible and realistic. And in this small print you'll see there, the other thing we get asked is, why don't you mention smoking? Because we kind of want that just to be the assumption that don't smoke. So not smoking and avoiding other exposures to tobacco and excess sun are also important in reducing cancer risk. Following these recommendations is likely to reduce intakes of salt, saturated and trans fats, which together help prevent other non-communicable diseases. So that's in the small print there. I mentioned this earlier, that we have this healthy weight, one recommendation, be physically active, and then all of these for diet and nutrition, because if you just tell someone, eat a healthy diet, that means many different things to many different people. So you have to sort of break it down into components that they can actually use and put into practice. A little bit of repetition from this morning, really a forest plot. It gives you a way to summarize. So this is a linear dose response meta-analysis, so you end up with a summary estimate at the bottom. This one just happens to be for alcohol and breast cancer. The non-linear, so for breast cancer and alcohol it's pretty linear. I thought I'd put in, is this a pointer as well? No.
The green firework is a laser.
The green...
most bottom part of the circle.
I'm just going to point. So you can see what a linear one looks like, or even though that is a non-linear analysis. But you can see the bottom right hand there is for colorectal cancer, where somewhere between 1 and 2 drinks, one drink isn't significantly associated, but then it goes up. And there are some pretty interesting different shapes for different cancers for those analyses. Now I've messed up my... Okay. So maintaining a healthy weight is after smoking, the strongest risk factor, or having a higher BMI is the strongest risk factor for cancer after smoking. Ensure that body weight during childhood and adolescence projects towards the lower end of the healthy BMI range. Keep weight as low as you can within the healthy range throughout life, and avoid weight gain. And that's based on its role in 12 types of cancer, IARC, so the International Association for Research on Cancer, based in Lyon, France, which is part of the World Health Organization. They say 13. I think it's a brain one, and it's gone from my brain. Meningioma is the additional one that they assess to be obesity-related. But these are all some of the most common cancers. So, and as I mentioned earlier, any of the new people not in my talk this morning? Just so I'm not... No? Good. So, the prevalence of obesity is high, the contribution to risk is high, and as smoking rates come down and overweight and obesity continue to go up, this is becoming a bigger and bigger issue. The specific mechanisms are, there's definitely an inflammatory component, there may be an immune component, but we know that association is there. And I'm going to talk at the very end about how to avoid the sort of victim blaming, in the same way that we know that somebody who smokes who gets lung cancer, yes, the likelihood is that it's due to smoking, but we don't know that for sure, and we need to remove that stigma. And because the relative risk for smoking is still a lot higher than it is for obesity, but you can live a perfect life with a perfect BMI, perfect diet, all the rest of it, and still get cancer. So I've got a little analogy at the end of all of this to maybe help communicate that. Be physically active. Make it part of your everyday life. Walk more, sit less. Be at least moderately physically active, and follow or exceed national guidelines, and limit sedentary habits. So all this sitting around in conferences I should really make you all jump up, but but I'm sure you're all going on the run at 4 o'clock. The strongest evidence is in colorectal and endometrial cancer, and both postmenopausal and premenopausal breast cancer. And this is independent of independent of obesity. You think, oh, physical activity, it must be because they're more active and they're lower weight. This is actually independent. And I think this is an area where the immune system is likely the key to it. Because actually every bout of exercise releases immune cells into your bloodstream. And they're actually using that in bone marrow transplants and things now. So exercise is a powerful medicine, but I know you know it. Getting into the dietary ones. Eat a diet rich in whole grains, vegetables, fruits and beans. So when I was presenting this earlier, I was kind of selecting the ones and focusing the ones that were focused on breast cancer. This diet does have an impact on breast cancer, but a lot of this is really operating through colorectal cancer. And anyone who's got the book, if you open up page 46, you'll see the strong evidence matrix that colorectal cancer has 10 factors that we know are strongly related to cancer risk. Breast cancer is about 7. Prostate cancer is the one, probably the most common cancer that we don't know, other than for advanced prostate cancer, adult obesity is associated with a stronger risk. But we really don't know what in lifestyle is the driver of prostate cancer. Anyway, So this is for whole grains. So for each 90 grams of whole grains per day, you have a 17% reduction in risk of colorectal cancer. So swapping out that bread, and I've pretty much against my kids' demands, I've pretty much switched to whole grain pasta. So there are ways to get your whole grains in, and it's certainly good for your, and this probably operates partly through fiber, but whole grains themselves seem to have, it's not just the fiber, it would seem. Fiber is certainly part of the story. For each 10 grams of fiber per day, you're reducing your risk of colorectal cancer by 9%. And I presented this earlier. Really, the further you can get along that dose increase, the greater your reduction in risk. If you're in that less than 30 grams per day of fiber, you're not getting the benefits. Yeah.
Could you please speak to the different kinds of fiber and whether or not any kind of fiber works, or do we have to have a specific kind?
Dietary fiber rather than the Metamucil type thing, yeah. But no, I mean, if people are eating a higher fiber diet, they're getting a mixture. So we wouldn't say, soluble, insoluble. Just get plenty of fiber in your diet. Limit consumption of fast foods and other processed foods high in fat, starch, and sugars, as I mentioned earlier. This is really operating through obesity. We did the determinants of weight gain, overweight, and obesity. The factors, if you're eating more whole grains and fruits and vegetables, you're likely eating less of the fast foods. Mediterranean diet in there. Increasing your risk, the Western type diet and the fast foods. So just while I'm on this slide, because it doesn't come into any other part of the discussion, the distinction between how we assess the evidence, we basically use the modified Bradford Hill criteria that were first published in the 1960s, which is the size of the effect, the volume of the research, what are the other? There's like 6 of them, and the types of study designs that are used. Screen time, we have a convincing, an assessment of convincing evidence. This is all probable and convincing is considered strong evidence, strong enough that we could make a recommendation for it. But for adults, it's only probable. Now, does anyone have any idea why that might be? Very close. The quality of the studies that are done. So in adults, it's almost all observational studies. And in kids, there's been a lot more interventions and randomized trials. So we have stronger evidence in kids than we do for adults.
I'm sorry, this slide is linking physical activity and screen time to the outcome being obesity?
Yes. This is the determinants of weight gain, overweight, and obesity, which is a strong risk factor for cancer. So we can't say screen time causes cancer. I'm not remotely trying to say that, but it increases your exposure to an important. I'd love to be able to tell my kids that, though. Limit consumption of red and processed meat. Eat no more than moderate amounts of red meat, such as beef, pork, and lamb. Eat little, if any, processed meat. Basically, oh, no. What have I done? How do I get back? There we are. I might just use the arrows on here. I'm finding that mouse. So this is for red and processed meat. So 100 grams per day gives you a 12% increased risk of colorectal cancer. And I can't remember. So if you do a similar analysis for processed meat, you get a very similar risk for half the amount. So for 50 grams per day of processed meat, you have a 12% increased risk of colorectal cancer. So basically, for whatever reason, and there's lots of different hypotheses out there, processed meats are a more potent carcinogen. But even for red meat, so if you look, the cooking-dependent ones are these heterocycloamines and polycyclic aromatic hydrocarbons. My PhD was on those sort of phase 1 and 2 enzymes. Those are the cooking-dependent mechanisms by which red meat may increase colorectal cancer risk. You then have these cooking-independent factors. So new 5-GC is basically a glycan that's found in red meat that gets incorporated into our membranes. We don't have, most mammals actually have the ability to metabolize it. We don't. So it gets stuck in our membranes and can cause an inflammatory response, and inflammation is a big driver of cancer. The microbiome is influenced by meat consumption. Heme iron is one. So what I'm basically saying, there are so many different mechanisms by which this can happen, both cooking dependent and independent. I don't think we're ever going to get to the bottom of this, but we know that the association is strong and consistent, and so why don't we say no meat? We pretty much try to say to people like no processed meat, but red meat can be an important part of diet, and you do see that that red line is basically above that is where it becomes statistically, or where I feel like I'm attached to something. I'm attached to myself. This is a confidence interval, so it's kind of out here that that it becomes a significant risk, and so we say limit meat consumption, but there's not the strong justification to say you mustn't eat it at all. Whereas for processed meat, sure, if you want to have a hot dog at a ball game, or I had a couple of rashers of bacon at breakfast this morning, but not daily consumption. Limit sugar-sweetened beverage consumption. I said these are the scourge of our society, I think. 12 teaspoons of sugar. I mean, if you showed people what is actually in these drinks, they are just syrup. They are the largest contributor of added sugars. Half of the population consumes one of these on any given day. Sure.
What about replacing it with diet? You hear everyone.
So there was an article there was an article this week. Actually, the World Health Organization just came out with a statement saying that they were recommending basically against people drinking diet versions. We recommend drink water or fruit juice, but only one thing of fruit juice a day because that's also high in sugar. The evidence for the non-nutritive sweeteners it's very different for different ones. There are lots of different versions out there. It was only this week that the WHO came out with that statement, and I haven't had a chance to dig into it. In the past, we've said, just try and avoid fizzy drinks in total, but particularly the sugar and sweetened ones. And this is not just for cancer. The little bit I did read on the WHO statement was also addressing diabetes, and not so much. And they said, using them as a way to reduce diabetes wasn't effective. But I just avoid these. You know, I think there are so many alternatives that are not diet. You know, there are beverages. You know, my typical drink is water with a squeeze of that, the lemon juice that you get in and I think it may have sulfates in it, but sorry.
Breakout for these studies regarding the type of sugar. We had a speaker here a few years ago who had some pretty compelling information on high fructose corn syrup as a sweetener versus.
Yeah, my kids consider me the highest fructose corn syrup Nazi. Like they put something in the trolley cart at the supermarket, and I'm like, so yeah, I think the evidence certainly relating to cancer is still out, but I mean when you look at NAFLD and NASH, we have an epidemic of it that's. And I think there's pretty good evidence that's liver cancer rates are going up because of non-alcoholic fatty liver disease, and I think the high fructose corn syrup, although we call it non-alcoholic fatty liver disease, it's basically metabolized just like alcohol. So in some ways it kind of is not my area of expertise, but yeah, seek alternatives. I think is the.
Is the link there with these sweet drinks really just the obesity?
Yeah. We don't have the direct evidence and I don't even like the studies that have looked in. There's been some in survivorship, and I think there was one that said that in colorectal cancer, diet drinks were associated with poorer outcomes, but people are drinking the diet drinks for a reason, generally because they have pre-existing obesity. But yeah, there's the mechanism for this is through added sugars leading to higher body weight and all the inflammation.
Just curious, isn't that a superfluous recommendation? And once you've established the link between obesity, overweight, and cancer, what's the point in drawing attention to?
Again, to break. Well,
it's all the same thing, isn't it?
but that's why we break down. It's the largest contributor of added sugars and calories. So rather than just saying, eat a healthy diet, drink healthy drinks, then people may say, oh, well, I'm going to drink juice. Yeah. So the recommendations there just to help people try and have a template for a healthier lifestyle and diet. Limit alcohol consumption. So obviously my focus earlier was on breast cancer, but there are 6 types of cancer: head and neck, so mouth, larynx, pharynx, esophageal cancer, liver cancer, colorectal, breast and stomach. There is a protective effect of alcohol consumption on kidney cancer. We don't know exactly why. I wouldn't recommend, if you want to justify having a drink because it's protecting you from kidney cancer, but it's a pretty consistent, strong association. This is just to give you an idea of the size of the effect, and the fact that other than breast cancer, colorectal cancer is more common in men than women. Liver cancer is much more common in men than women. Esophageal cancer is much more common in men than women. So the alcohol thing is not just about breast cancer and women. It's these are each of these is for 10 grams of ethanol, so not even a full measure of alcohol. Whether it's in wine, beer, spirits. And and you can see 5% increase, 2%, 9%, 7%. For esophageal cancer, even one drink is a 25% increase in relative risk of esophageal cancer. So there's some pretty strong effects.
Yeah, I just asked, are those real rigorous studies? I mean,
Yes.
how do you study to the level of 10 grams of ethanol?
So most.
Studies where you randomize people?
No, these are observational studies, but people report their alcohol intake, and these are based on meta-analyses of prospective cohorts. So this isn't, one of the problems with case control studies is that people have an idea, if someone's a heavy drinker and they're in a case control study, they may, in either direction, they may underreport. Actually, people tend to underreport their drinking regardless. Hilarious example is in Canada. In some of the provinces, you have state-registered liquor stores, and if you look at how much alcohol is sold, and you do surveys of how much is consumed, half of the alcohol being bought is being thrown away because they're not drinking it. And it's the total opposite for fruits and vegetables. People are eating twice as many fruits and vegetables that are actually being sold. So they must be getting it on the black market or something. So, there are some limitations, but these are, as I was saying, the modified Bradford Hill criteria take into account all of the limitations of the evidence, and it's only, these are all strong evidence conclusions. There are other types of cancer for which there may be a suggestive effect, but these are the ones where you're like, no, this is convincing or probable. And this is just, for esophageal cancer, any amount of alcohol increases your risk. For colorectal cancer, it seems to sort of, that very low consumption doesn't increase your risk. But in any kind of cancer prevention setting, you don't know what cancer we're all at risk of, apart from gender differences, we're all at risk of any cancer. So anything you can do to limit that. Liver is the one that really surprises me, because you would think that's going to be the first one that gets hit. And you really need to drink quite a lot of alcohol to get liver cancer. But, we just go by the data. Doesn't matter what you drink, it all increases your risk. Don't use supplements for cancer prevention. There are reasons to take supplements. There is a little caveat here that calcium supplements do have a preventative effect on colorectal cancer, but they also increase, or higher calcium diets and calcium supplements may increase prostate cancer. So this is the use of calcium supplements for colorectal cancer prevention is really a sort of a clinical decision, but we wouldn't recommend that the whole population to start taking calcium supplements to reduce their colorectal cancer risk. Breastfeeding, we spoke about earlier, it's good for the mother, it's good for the baby, and basically our recommendation aligns with the WHO. And after cancer diagnosis, follow the cancer recommendations if you can. And we really focus this on the post-acute treatment phase, but as long as you can, maintain a healthy diet through your treatment. There's been a huge change. So I was treated for cancer in 89 to 90 and 92 to 93. And back then, it was still, you got very sick from the treatment, you lost lots of weight. And most of the population were in a sort of normal BMI range. And people who were trained, and oncologists and nurses who brought up through that, there's still this sort of almost sort of motherly thing of, you must eat, you must eat. But 70% of the cancer patients now have overweight or obesity. So, it's not just about getting calories in, but getting good quality, nutritious food in. I spoke about this earlier. So this was from 2014, when the quality of the evidence was not sufficient to draw any strong conclusions. We now have strong evidence, at least for BMI. We don't yet have strong evidence for weight loss, and this is definitely going to differ between different types of cancer. Breast cancer patients tend to put on weight through treatment and often struggle to lose it afterwards. Colorectal cancer patients, there's some evidence that people that are slightly higher BMI actually have better outcomes. Head and neck cancer patients tend to have better outcomes if they have a higher BMI diagnosis, as do... So any of the cancers that have a higher propensity for that sort of cachexic, wasting response, there may be some advantages to having a bit more weight at diagnosis, but you've got to balance that a bit against increasing your risk. But we're certainly not at a point for those other cancers where we would recommend weight loss, certainly during treatment. After a diagnosis, cancer patients are at greater risk of cardiovascular disease. Most women that are diagnosed with breast cancer actually die of cardiovascular disease now rather than their breast cancer, because outcomes are so good. I mentioned this a little bit at the beginning about quality of life. So we only have this for physical activity. The benefit of this is that these were mainly randomized control trials that were done. But physical activity does improve health-related quality of life in women with breast cancer and after breast cancer. So out of 91 publications, 78 were randomized control trials. It's really hard to do those kind of trials in the cancer incidence setting, because you just don't have, you would have to have them on a 20-year exercise program. But in we can actually show strong effects, increasing health-related quality of life. And this is just to give you, these are some of the different scales and tools that are used to measure it. And it's also broken out into domains of general health, their feeling of general health perception, their physical functioning, their emotional functioning, mental health, all of these things. And it's down to, it's not just about staying alive, it's about living. And physical activity helps with that. What do we know? So in the back of the book, it's actually the very back page pulls out into a sort of fold out. And this gives not just the strong evidence, but all the limited suggestive. There's a lot of gaps. We're never going to fill all of these gaps. And this is broken out into the effects of fruit and veg. These are all the cancers down the side. And then you've got fruit and veg, red and processed meat, diet and nutrition, body fatness, physical activity. And I mentioned prostate cancer. You have only way over here in adult body fatness, and all the others are limited suggestive. It's a super common cancer that we really don't know much about how to prevent through lifestyle. And this is a strong evidence matrix, so only showing the ones that we have evidence that's strong enough to make recommendations. We have the scoring system, so we can measure people's adherence, and there's really a lot of evidence starting to come out, because a lot of this data is already sitting there in these cohorts, and now they can just analyze it fit basically people's exposures to the score, and then look at their outcomes. And NCI has a a page dedicated to this to help people find the resources for using the score. A couple of the components of the score are kind of two-part. So you have BMI and or waist circumference, and for the grain one there, that's whether you have dietary fiber or just a sort of a measure of fruit and vegetables per day. I mentioned the cancer health check. I know a couple of people have mentioned they've gone in and had a look at this and done it. It's very intuitive, very good way just to get a broad idea of how well you're meeting the recommendations. And the Healthy Challenge is a program, free, 10 weeks, to help people meet the recommendations. And we have lots of resources. I'm just going to touch briefly on lifestyle genetics, because when we published the third expert report in 2018, we had sort of internal discussions and with our panel, and say, well, this is particularly important for people that are at a higher genetic and familial risk. And I was like, we don't actually have that evidence. I mean, intuitively it makes sense, but it could also go the other way, that genetics totally overwhelms lifestyle. And what's just come out in the last couple of years is an increasing volume of research saying that following the recommendations is even more important in people at a higher genetic risk, which is good, because that means we can do something about it. There's a smash, and there's more and more of these coming out all the time. It's a bit of a tsunami of them. So I said I would end with this analogy. Who's ever heard of the cancer lottery analogy? So this was something I'd used for a long time, because people say, "Oh, well, how come you got cancer?" And my granddad smoked all his life and he didn't get cancer. And we're all born with a cancer lottery ticket, and basically our behaviours either enable us to purchase more, but it's kind of the lottery you don't want to win. But everyone is at risk. So I'd used that a lot. And then it was last year I was cycling to work, and I was actually trying to think about how to communicate progress in cancer research. And I had this idea of the bathtub filling up. And I was like, that's actually a better analogy for cancer risk. So I had this idea that, when we accumulate cancer risk, and when we've accumulated so much genetic damage that it's cancer, that's the overflowing, and cancer, escapes its local surroundings. And I thought, well, that doesn't account for that random element of cancer, because we're all born with some water in our cancer bathtub. So I thought, well, it's an old-fashioned clawfoot bathtub with one wobbly leg. And that's why, if we can keep the level of water low in our bathtub, then we can avoid cancer. But there is still that random element of that can just be a spontaneous mutation. It can be brought on by also other diseases causing more inflammation. But this idea that avoiding that accumulation of risk. So how do we know how full our bathtub is? We know from screening studies where we have these pre-malignant lesions that for a lot of people their bathtub's getting pretty full by our 50s. I'm 52. And we can never turn, the other thing is we can never turn, it's a bathtub with a leaky faucet. There is this constant accumulation of water. But sometimes that can become a greater flow. And our risk increases with age. This is the cancer incidence histogram, and you can see it really starts to accelerate in our 50s and 60s. But it's never too late or too early to try and control that flow and stop that accumulation of damage. So we want to keep our risk as low as possible, and we know that following these recommendations is an effective way of keeping risk low. So in this analogy, reducing that intake of water. The other part is policy. And policy basically lowers the pressure in the whole system so that drip, drip, drip makes it easier that people aren't having to make individual decisions about their exposures. The policy work is very slow, but it's definitely something that could help augment personal decision making. So, having President Biden say cancer is a disease that we have few good ways to prevent, I would say no. We know that approximately 40% of cancers in the US could be prevented with the knowledge that we have right now. And so that is partly awareness. We do risk factor awareness surveys every few years. And there's this dichotomy between about half of the people that say, well, we've heard all this before, and then the other 50% that are like, what? Alcohol causes cancer? Red meat causes cancer? So we keep banging the drum. And there's the awareness part, and also trying to implement policies that can make it easier for people to make those changes. So, thank you very much. Yes?
You mentioned we shouldn't encourage people to take multivitamin supplementation in order to prevent cancer. Should we discourage people from taking multivitamins? 10 years or so ago, I read a review article about cancer rates in people who took multivitamin supplement versus those who didn't, and they were reporting more cancers, more aggressive cancers.
So I would say we should discourage people from taking supplements if their goal is cancer prevention. We should also discourage people from taking supplements during treatment, because some of these supplements can actually reduce the efficacy of the cancer treatments. But I mean, if people are taking them for osteoporosis or whatever, they should keep doing that because there is a medical reason for that.
Yeah, but just taking a supplement because they think they're going to be healthier.
Yeah, and also, it tends to lead people to say, "Oh, well, I don't like vegetables, so I'm just going to take a supplement." There is so much more benefit from eating a proper diet. You can't replicate it with a pill.
For the benefit of our Zoom audience, I'm going to, for questions.
So, what do you think about these keto breads that are out? The white breads, the low carb. Some of those have like 15 grams per bun. And it seems like it's just added fiber, right? Which would be very similar to Metamucil.
We don't have the evidence yet. The whole ketogenic diet story it's interesting. We think of dietary patterns, and most of the research has been on Western diet, Mediterranean diet, the various named diets. Consumers are now thinking ketogenic diet, low carb, and we just don't have the research yet. Most of the time it's used for weight loss. From what I can tell, ketogenic diets can induce quite rapid weight loss, but it's not sustained. And we don't have evidence yet on, even if people could sustain the weight loss, we don't have evidence about the formerly obese or the former with obesity, or try to use person first language, the way we did with smoking, former smokers, and how the cancer risk goes down relatively quickly after you stop smoking. We don't have that evidence for obesity. But yeah, for the ketogenic diet, I think one of the problems is that they typically are not getting the amount of fiber. They're not getting the non-starchy vegetables even. So there are people. There's a drive, particularly at MSK in New York, looking at, rather than ketogenic diets, they're insulin-reducing diets. So I think watch this space, but we just haven't had long enough.
One of the 10 things.
Because it's driven so much by smoking.
What about, so is red meat its own independent risk factor, or does it go along again with obesity with, like, drinks?
No, red meat is a direct association between red meat consumption. And as I said, there are a host of candidate mechanisms, but the association has been very strong and consistent.
Is EB still considered a cancer risk?
Is what, sorry?
EB virus.
Epstein-Barr, yes. For nasopharyngeal and, Burkitt's lymphoma. But, we don't focus, cervical cancer is 100% HPV. Pretty close. So yeah, there are a whole load of other mechanisms outside, but these are the things that we do recommend, following the screening and vaccination as well.